Hello, everyone. My name is Ahmed. I'm a third-year pathology resident, and today I'm going to be talking about acute megakaryoblastic leukemia. This is an acute leukemia that is characterized by at least 20% blasts with megakaryocytic differentiation. Some of these acute megakaryoblastic leukemia cases are associated with mediastinal germ cell tumors in young men. The pathogenesis. There are three clinical groups. The first group is adults. The second group is children with Down syndrome. And the last group is children without Down syndrome. In children without Down syndrome, over 75% of the cases have chromosomal translocations like CBFA2T3 GLIS2 fusion, RBM15 MRTFA fusion, NUP98 KDM5A fusion, and KMT2A rearrangements. Morphologically, on the bone marrow aspirate smears, blasts vary from small to large. A few scattered binucleated and occasionally multinucleated blasts may be present. The cytoplasm is basophilic and agranular, and sometimes has cytoplasmic plebs, and these plebs are not specific for acute megakaryoblast leukemia or for megakaryoblast because they can be seen in pro-erythroblasts, in acute erythroid leukemia, they can be seen in lymphoblasts, and they can sometimes be seen in myeloblasts as well. Some cases have megakaryocytic dysplasia and micromegakaryocytes. However, these micromegakaryocytes should not be counted as blasts at all. And in some cases, megakaryoplasts appear somewhat cohesive and can mimic clumps of metastatic tumor cells, so just be careful. As for the immunophenotype, these blasts are characteristically positive for megakaryocytic markers, including CD36, CD41, CD42B, and CD61. CD36 is not specific at all. Cytoplasmic expression of CD41 and CD61 is more specific than surface expression. And the reason for that is that sometimes platelets can adhere to blasts, whether myeloblasts or lymphoblasts. And then if these platelets adhere to the surface of these blasts, they're going to express CD41 and CD61, which are antigens that are present on the surface of platelets. Among myeloid-associated antigens, CD33 is positive, MPO is negative, and the rest of the myeloid markers are variable. CD34 and HLA-DR are variable as well. And then we do have what's called the RAM phenotype, and RAM stands for the initials of the first patient who was diagnosed or in which this phenotype was identified. This RAM phenotype means strong CD56 expression, variable or moderate CD34 expression, variable CD117 expression, and negative expression of CD7, CD11B, CD13, CD36, CD45, CD38, and HLA-DR. This phenotype is distinctly associated with CBFA2T3 GLIS2 fusion. An acute megakaryoblast leukemia caused by this fusion has a poor prognosis. Immunohistochemistry staining with von Willebrand factor is positive in biopsy sections. To make this diagnosis, you need to identify at least 20% blasts with megakaryocytic differentiation in the bone marrow or the peripheral blood. These blasts should express at least one of the platelet glycoproteins, CD41, CD61, or CD42B. Criteria for other defined acute myeloid leukemia types should not be met. You have to exclude history of myeloproliferative neoplasm. Differential diagnosis includes acute myeloid leukemia with RBM15 MRTFA fusion, which can have megakaryoblastic morphology, acute myeloid leukemia with MECOM rearrangement, and other types of acute myeloid leukemia defined by differentiation. Cases in patients with a history of chronic myeloid leukemia or other forms of myeloproliferative neoplasm that have transformed into acute megakaryoblast leukemia should be classified as myeloproliferative neoplasm in blast phase. A desirable criteria is evaluation for possible Down syndrome. This entity is rare, and the prognosis for this entity depends on the underlying molecular mechanism. For example, patients with CBFA2T3 GLIS2 fusion have poor prognosis. This is the end of this video, and see you next time.